And Gail, that'll just, I'll pause that for.
Want our voices heard at the podium, in the boardroom, and at the investors table. We want our voices to be proficient, inspiring, and confident. We want our voices leading innovation, patient care, and opening doors for others.
The Ignite Healthcare Network is a nonprofit organization dedicated to enhancing the influence, proficiency, and entrepreneurial talent of women leaders in healthcare.
Women are, as we all know, vastly underrepresented in the founder community among startups, also in the investment community, and also in the healthcare community. So every part of the chain, there is a challenge.
Ignite is attracting women healthcare executives or women in healthcare that are from such a diverse background, that by connecting us all together, it in of itself creates innovation.
Really creating innovative solutions, not just in technology, but in sciences and other programs.
Formed in 2017, Ignite's programs, networking and mentoring events, and accelerator competitions promote the advancement of women leaders transforming healthcare.
Sort of Ignite to me is creating this diverse portfolio of women and possibilities.
It's almost daunting, the talent and the accomplishments, the skills that are in that room. But once you start talking, that's not what you hear. It's the support, it's the camaraderie.
Ignite allows me the opportunity to stretch. It allows me the opportunity to get exposed to areas where my own area of expertise, may not be enough. I am learning.
The knowledge members gain and connections they make ignite ambitions, fuel leadership, and spark answers to critical decisions shaping the industry.
You can expect to be surrounded by enormously accomplished women who are there to support you and to collaborate with you.
To really make a difference in healthcare, technology, or STEM programs.
There's no limit to what bringing diverse talent together can create.
For us, the sky's the limit.
Good morning. It's Aisha McCracken. I hope you are all well this morning. Give me a minute as I put together my, get my presentation up for you. Apologies. There we go. Good morning. It is my pleasure to welcome you to day 3 of Ignite's pitch sessions. I say good morning, but for you, for some of you, it's good evening. And we appreciate everyone joining us today for another great day of pitches. Yesterday, we had an outstanding day of 11 pitches that we got to enjoy hearing and see some really promising entrepreneurs. Ignite, this is our 5th year of hosting these types of events, and we are delighted by the continued growth and reach that we have in finding women doing great work. We now partner with organizations in Australia, in Israel, in Denmark, in the UK, and really are getting some incredible talent applying for our program. So we're thrilled that you're here, and we look forward to hearing some great pitches from 32 companies that were selected from a group of 130 that completed their applications this year. So this is a process, and there were 263 companies actually that were engaged in the process, and 130 actually completed the applications. We had 120 hours of volunteer time, and some of you are on this Zoom call this morning who volunteered your time to help us assess and pick the best of our applicants, and that's who you're going to hear from today. You're going to hear from 5 companies and learn more about their businesses. But we are grateful to the people that the VCs, the clinicians, the folks who gave of their time to help us identify these companies. We couldn't have a program of this nature without surrounding ourselves with some incredible organizations. And so the mini accelerator partners, we've had many organizations that represent the customer of these startups and that represent potential investors of these startups. Our program, once the cohort is identified, matches startups with a partner from each column here, from an investor voice and a customer voice. And they learn a lot through these interactions. It's a 6 to 8 week program. And then they help prepare for the pitches that you are going to hear today. So we thank all of the outstanding organizations and the teams that have given of their time to help prepare the startups to get to this point today. And of course, we can't survive without our sponsors, and we have been fortunate to have sponsors who've been with us for a number of years. And you'll hear a little bit more about the work and the support we've had from the TMC Innovation Group really since our inception. And you'll see a number of these organizations as the program continues, and even to our finals, which is scheduled for January 20th of 2020. We have a lot of support from these outstanding organizations, and we are grateful for their continued support for this year. So as we get ready for today's program, I wanted to point out a couple of things. First of all, each panel will have a winner that is selected from the judges' votes. So judges, we keep reminding you, and we really appreciate you completing the scoring tool. It's your scoring that will determine the winner from this panel. But also for the audience, there's a People's Choice Award. So you can view all pitches. We'll have them posted, the recordings on the Event Hub. And they should be posted, I say, at the end of each day, but we will send out notice on Whova as soon as they're posted And even for our judges, you can go back and listen to pitches you weren't a part of judging, and help identify a winner, vote for a winner. And there's the SurveyMonkey link that'll be posted in Whova as well. Voting is going to end 11:59 Houston time this Friday, the 15th. So please take a look. From the last look, there's a lot of voting going on this site already. So we're excited to see who will win the People's Choice Award. I wanted to also make sure that you have on your calendars the date for the grand finale, which is the final competition will take place in person January 20th, 2020. We'll have a VIP session or reception January 19th, the evening prior. It's scheduled to be at the Ion. And so we're thrilled to be able to bring the finalists to an in-person competition in January, and we hope you can all join us. So with that, let me introduce this session's moderator. Sarah Hill is CEO of Helium. Helium's a mental fitness product for human performance that teaches the user to self-regulate their own brain waves and heart rate. Sarah was one of the winning companies from last year's pitch competition. We're delighted to have her with us to moderate today's session. Sarah, thank you for being here, and I'll turn the session over to you.
Absolutely. Thank you very much. So great to see so many familiar faces in the audience, and so appreciate that you give a great platform to all of these awesome companies. So good morning, everyone. Welcome to the Ignite Fire Pitch 2021 semifinals. Today, we'll be hearing from women-led healthcare companies as they pitch to a great panel of industry expert judges. And today's event would not be possible without great sponsors. So please do learn more about who they are and what they're doing on our sponsors page, or you can also click directly on their logos throughout the event site. Each one of them has helped us make this event bigger and better. And a special thanks to J&J and Texas Medical Center Innovation for their many years of support. Right below this video window, you can scroll down to learn more about the speakers and also the judges participating in today's session. The companies themselves are listed towards the bottom of the page, and each company will have 7 minutes to present, with 8 minutes of questions by our judges. All right, everyone, sit back and relax, and it is time to get started. First up, please welcome to the virtual stage, Steen Molgaard Sorensen with Radiobotics. Steen, good luck.
Thank you so much. Let me share my screen. So do you all see this nice hand?
Yes.
All right, so let's start the time. So hi, everybody. My name is Stine Sorensen. I'm the COO and co-founder of Radiobotics. And at Radiobotics, we built machine learning algorithms that can automate the reading of musculoskeletal X-rays. This will provide efficient and consistent and cost-effective analysis and reporting of the X-rays. We are targeting radiologists and emergency care doctors who are all suffering from a global challenge where lack of qualified staff is only increasing. Today, more than 250 million X-rays of only bones and joints are being taken in Europe and the US combined. This number is only growing day by day. But the number of qualified clinicians is not growing nearly at the same rate. And in fact, it actually takes more than 10 years to become a specialized radiologist. This leads to fatal errors, delays, and unnecessary stress for the patients, and a much higher workload for the radiologist. And actually, recent numbers are showing that radiologists are among the most burned out physicians. And then I could ask you if you would like to have your X-ray read by an overworked staff. And I'm not sure that I would. So this cannot be solved by educating more radiologists and clinicians. It simply takes too long. So I believe it's time to introduce new technology that can improve the lives of both the patients and the doctors. And by big surprise, this is of course what we're working on at Radiobotics. Here you see an image of our MDR and FDA cleared technology, and we have 16 pilot agreements with hospitals today across Europe and US. We have, among others, partnered with GE Healthcare and VRAD, which is US largest teleradiology company, and our technology is doing more than 5,000 analyses a month. Based on advanced computer vision and deep learning methods, we can in real time perform an analysis of the X-ray right after it's acquired. Our output is, as you see on this slide, is a secondary capture, and it's fully automated text report describing findings and impressions, which is easily integrated into the hospital's IT system. We're already integrating into the 5 largest PACS providers, being already available in many areas. We have a strict focus on identifying diseases in only bones and joints using 2D X-rays. This places us in a unique spot looking at the competitive landscape where most focus is on other modalities like CT and MRI and high-risk pathologies like cancer and stroke detection. We aim to have the world's most comprehensive and best performing product portfolio. Our first product will open doors and lead the way, but it's our future portfolio that will be the main differentiator. We especially see that our extensive product portfolio will bring value to both the patients so they can receive faster diagnosis and initiation of treatment, to radiologists and ER doctors who will be able to ensure a fast turnaround time and high and consistent quality in the reporting, to referring physicians so we can reduce the risk of misdiagnosis and receive a much needed second opinion, and also for hospitals and larger systems where we can ensure an overall consistency and reduce the cost of outsourcing to teleradiology. We are founded in Scandinavia. This is where we develop with a very easy access to Denmark's largest radiology department just in our backyard. And we're looking to scale and commercialize in the UK and the US, because this is where we have experienced the biggest demand and a readiness to adopt AI technology. And that's also why I'm personally very excited to be part of the Ignite program, because this is really where you get to meet professionals who can actually help us support our journey. We have identified several commercial paths. And we can sell directly to the hospitals and smaller clinics, create partnerships with academic institutions and PACS providers, and co-develop with leading hospitals and teleradiology companies, like we're already doing with ReRad. Today, we have 5 paying customers, and our business model is software as a service based on a licensing agreement, charging $2 to $6 per scan, and a little higher in Europe due to different reimbursement rates. However, we need to focus. So our first customer profile will be radiology departments at academic centers placed in urban areas where they can attract the talent they need and where they are relying on teleradiology. We're close to signing our first US commercial contract with UTMB, creating a business case where we can save a substantial amount of money. For this year, we want a total of 25 pilot installations in 5 countries and 5 partnership deals with leading PACS providers. Our focus is on usage and installations because we think that is a difficult task to overcome right now. And then we are preparing for much more substantial revenue in 2022. The commercialization in this area is still early and debatable. The predictions look good and very promising if you ask me. And we expect that we can take up just 10% of the MSK AI market and reach an ARR of $50 million in 2025. We're only 4 years old, but we have managed to create an award-winning team of 20 employees. We already have the crucial regulatory approval to sell our software in the EU. We even have MDR certification, which is the highest standard in Europe, and we're one of the first companies to receive this. We also have our FDA clearance, our 510K clearance we got a month ago. We have clinical partnerships with leading European hospitals like Charité in Berlin, which is the world's largest university hospital. We have also been part of Texas Medical Center's Accelerator program, which has given us a strong confidence that the US is an important market for us. And I'm proud to say that Radiobotics has also incorporated in the US. We've also been nominated for the Future European Unicorn Award by Digital Europe, and we have several patents pending protecting our technology. Here you see my 3 other co-founders. Mads, he's a biomedical engineer specialized in medical imaging. He worked at a prestigious university hospital in London. And next to him, you see Pavel. He's also a world-class engineer specialized in computer vision and deep learning. Martin, next to him, has a PhD in machine learning and medical imaging, and he's responsible for our data management, clinical validation. Myself, I have for more than a decade been working with digital transformation, and I've already had a successful Silicon Valley exit, and I'm also an author, and I sit on the Danish Innovation Fund's investment panel, and I'm also awarded last year for the Entrepreneur of the Year by KPMG. Together, we are 4 strong people that can actually drive 4 different agendas, and I think that is a differentiator of what we do. This is the rest of my team. Together, we have experience with exits, filing patents, soft funding, equity funding, scientific publications, R&D, and data science. And altogether, we're capable of solving complex problems, not in the distant future, but right now. Despite our young age in a complex area, we have already managed to create several partnerships, get products out to both the European US market, getting customers in several continents, build a team showing we're well on our way, releasing the enormous potential where we in 2025 can cover up to 70% of the entire skeleton and solve substantial problems. Thank you very much. I'm ready for your questions.
Excellent, Stine. Thank you so much for that great presentation. And now we would like to have open the floor to our judges for Q&A, and that will go by 1 minute. And then on deck, heads up, Jennifer Miller of Navimize, you are next. Bring the judges on deck for Q&A for 12 minutes. Who from our judges would like to start?
I can start off. Appreciate the presentation. My question is, have you guys looked at any sensitivity and specificity data for your platform versus the golden standard as far as radiology reads?
Yes. So I just want to show you my latest study. I can't find it here. So yes, we have done multi-center reader studies where we are testing up against 3 different levels of readers. And the conclusion is there is a very high agreement with the output of our technology. That is also the basis for our MDR certification and our FDA approval as well. So yes.
Karen?
Hi, yes, that was one of my questions, so thank you. My second question is, software-wise, what would the company have to purchase? Is this capable of working with typical 2D machines that you find in most hospitals and clinics?
So yes, so actually we don't integrate into the modality and the machinery in the radiology department. We integrate into the IT systems of where they're viewing the images already, which is called a PACS system, so a picture archive communication system. That's where we integrate into, and that's what we see as a partnership working with GE Healthcare, Philips, Fuji, and all of those. And we are working on having many partnerships with these because we're not a standalone, but we integrate into existing software.
And is that integration pretty seamless or
Well, yes and no. It depends a little bit on the version that the clinic will have. So the newer, the better, because obviously it's also very evident that the PACS providers have not necessarily been entirely ready for AI algorithms as of now. But we can really see that they're working on these things, and GE is doing a lot. Some of the PACS providers, they have these marketplaces where they accumulate a lot of different AI algorithms, so you can choose for those. So they started by doing these things themselves. Now they create the marketplace that integrates into the modalities.
Thank you.
Sarper, your question is next, and then Ethan, you're after Sarper.
Excellent. Thank you for the presentation. So this could be really, in a sense, a competitor to GE and Philips, as they're working with you now on the integration piece. Is that in your exit strategy, and potentially they will be the ones that strategically investing on further maybe acquisition overall?
Yeah, it's a good question. So I'm very happy that I 2 weeks ago was on the stage of the Health Tech Summit in Copenhagen together with the AI lead of GE Healthcare, talking about how we were not competing, but how we were actually relying on collaborating, because these larger infrastructure or IT companies has decided to create the platforms where they can source all of the good technology and make that available for their customers. So as of now, we will not be competing, and they are not investing in actually building this technology, but yes, it could be a potential exit partner in the future when we obviously has gone from solving smaller problems to having a full product portfolio. Then in 2 to 3 years time, it might be interesting. And as a founder, I might also be a little bit more open towards that when I have shown much more impact.
So a connected question then, sorry, maybe it's the second one, but then in this case that for your business model for companies like GE or enterprise sales, and or for the hospitals or other smaller ones, and in a SaaS model, what is the business model in different clients?
Yes, so actually our business model is a SaaS model, software as a service, where it's a licensing agreement based on the amount of images, so the volume of the images that a potential clinic or hospital would have. And so we base it on that. And then because we are now working directly with the hospitals, we also then charging directly them. We will see over time that we will then obviously have a revenue share model with the partners like GE to share some of the revenue. And we also foresee that in 3 to 4 years time, most of our revenue would also come from these partnerships because they can scale and they can make it available to many more hospitals than we could do today.
Thank you.
Less than 4 minutes left in Q&A. Ethan, your question now, and then Ben Johnson, you're on deck with your question.
Hi, Steen, really impressive work. And as a data scientist, always love seeing the use of machine learning and AI in these new applications. One thing I was curious about was, it seems like there's this human machine sort of confluence here, and you're in some sense helping the radiologist scale. I was curious about kind of how much are you enabling them to scale, or is this replacing them to some extent? And could you talk more about sort of the speed to them being able to finish a report or diagnosis, et cetera?
Yeah, so I think it's a misinterpretation that we will replace anybody. So the thing is that we are up against that there are more images that has to be read. So we will have to deal with that. And as I said, we can't educate ourselves out of it. What we really would like to see and what we would like to do is making the radiologists better at what they already do. And what I also think is that some technology should take up and reading the more tedious challenges, as we're trying to do within the field of MSK radiology, where I think a lot of radiologists to spend their time in the very complex areas, identifying cancer and stroke detection with CT and MRI with the 3D modalities. So I actually think this is an area where we would see a little bit more of automation, but we're not here to take anybody's job. We're actually here to make them better and faster, but also more consistent. And as looking into the value propositions, we've actually seen the consistency is much more interesting than actually time saving, because that we're not going to take them away. And it takes quite a lot to actually remove one radiologist, but we're going to make them more consistent. So we, from a hospital system perspective, that if you can make sure that your x-rays are read equally the same time and that the patient get the right care the first time, we can create much bigger value. And this is some of the things we're exploring with the Danish healthcare system and also with the NHS in the UK as well, because this is where we can show substantial value, so to say. So it's actually more consistency rather than efficiency.
2.5 minutes left. Your question, Ben Johnson.
Yeah, thank you very much. It's kind of a little bit of a two-part question. The first question, part of it is just who is the decision maker on the part of the customer? And then what's the most important part of the sale process that you have to get right in order to get them over the finish line?
That's a very good question. It depends in which country, in which hospital kind of system, and which kind of department that you are targeting. So because there is not yet put a place, AI doesn't live in a special department right now in the hospital system. So it's actually a little bit complex to answer who it is. But I can at least tell who my first customer is in UTMB in Texas as well. And this is the vice chair of radiology that both has the decision power, the purchasing power, and is also reading these images himself. So he can shepherd this into the department. He has the decision to actually make a purchase as well. So he can do all of these things. And another thing that's very crucial for us to succeed is that he already have experience with purchasing AI technology, because that makes it much more different. So for us, it's very much about finding those that already have the experience with this. And that's what I actually say is answering a little bit your second question is the more experience they have in terms of data management, cybersecurity, integration, and all of these things, it is actually much easier to work with them that gets it. And that's quite evident. Another sort of barrier and another thing we have to consider is also the PACS system, because that's the IT system we integrate into. So that has to be of a little bit of a newer date, but we can work around those things. But the newer it is, and I
apologize, that's our time for the Q&A. We're at eight minutes. Judges, thank you very much. At this point, so much. Great job, Steen. We are going to take a minute break. So a minute break that's going to allow the judges to complete their feedback and their scoring. So we'll be back in 1 minute.
Thank you, everybody.
And on deck will be Jennifer Meller of Navimize. So that concludes our 1-minute break. Judges, hopefully that gave you some time to put some scoring in there. Please welcome to the stage Jennifer Melner of Navimize. Jennifer, your time begins now.
Okay, so hi everyone. I'm Dr. Jennifer Meller. I'm the CEO and co-founder of Navimize. And Navimize features an end-to-end patient communication platform with a unique virtual waiting room solution. I founded Navimize to address the problem of keeping patients waiting in the waiting room, which I did way too often during my years of practicing. And then when COVID hit, it really shone a light on a lot of the glaring inefficiencies of the healthcare system, and crowded waiting rooms were the most obvious example of a problem that simply will no longer be tolerated. So we're now seeing health systems prioritizing virtual waiting rooms and a digital front door. And here's a recent article from the Wall Street Journal where they also highlight that this is absolutely happening now. So a lot of you are probably thinking, well, what about virtual visits? Haven't they solved the problem of getting rid of the physical waiting room? So today, only about 20% of all visits remain virtual. So the physical waiting room is not going away. And while they are great, virtual visits actually created new workflow challenges for physicians. And physicians and health systems are now struggling to figure out how they're going to continue to offer virtual visits with traditional in-office visits, since they lack technologies to address these new hybrid types of schedules with both in-person and virtual visits. Navimize solves all of these problems. The platform integrates seamlessly with existing EMRs, monitors workflow, predicts delays, and then sends automated text messages to patients with real-time schedule updates. And our automated customizable messaging engine also enables providers to send any messaging they would like, whether it's visit or procedure-specific information, patient education, online reviews, and more. And the platform now manages these new hybrid schedules of office and virtual visits by sending one set of messages to patients who are coming into the office and a very different message stream to patients who are coming in virtually, even when these visits coexist within one schedule. In the last few months, we signed a contract with Presbyterian Healthcare Services in New Mexico, and that EMR integration is now in progress. We also signed a pilot contract with a second health system with the ENT department at Jefferson in Philly. And we've got a whole host of health systems and practices that are in our direct pipeline. And here's a quick peek at what that pipeline looks like. We're also excited to share that we just signed a partnership deal with Epion. Epion is a leader in the mobile registration space, and we have multiple additional healthcare companies with synergistic technologies that are in our partnership pipeline today. We estimate the Epion partnership to be an $11 million opportunity, with the additional partnerships topping out at over $40 million opportunity. We have a great team. I'm the company's CEO. I'm a physician with over 20 years experience practicing medicine in New York. And I graduated with an MBA with honors from Wharton in 2016. It was there that I met my co-founder, Kavita Mongol. Kavita is an engineer with over 15 years experience in tech implementation and strategy. So in brief, we're a team with deep experience in healthcare and tech. And we're growing. In the last year, we added 2 full-time employees. We hired an excellent full-time engineer, and we brought on a stellar biz dev and sales lead. Megan was the first sales hire at a digital health company called Validic, and was really instrumental in bringing that company from 0 to 9 million in ARR in just 5 years. We have some outsourced partners for marketing and offshore development health, and we have a host of really great advisors from VCs in the healthcare space to former CEOs of digital health companies to PR experts and more. The ambulatory care outpatient market is a very large and growing market, and that's where we are targeting. And this is a look at our business model. So for independent physician practices, we're pricing as a SaaS B2B company. We sell on a per provider per month basis. For health systems, we charge an implementation fee and then an annual contract fee. And then, as you can see, we return terrific ROI to our customers. So in terms of our go-to-market, we spent the first few years really working on taking the company from idea to product, raising early capital, building out our MVP, testing it, and iterating to achieve product market fit. We now have 10 paying physician practice customers. We have the partnerships with health systems. We have channel partnerships with EMRs, and we're working on increasing our brand awareness for inbound lead gen. And looking ahead, we want to go beyond what we've built today to add in data analytics and business insights for customers, as well as build out our vision of an intelligent scheduling platform. So scheduling today is broken. Everybody gets the same 15-minute follow-up, doesn't matter their age or what their medical issues are. And this really creates a lot of inefficiency. So our goal is to leverage data and machine learning to understand what drives appointment length and then create an intelligent scheduling platform that will schedule patients according to their needs, which will drive throughput, increase revenues, but also improve wait times from the bottom up and improve the experience for all stakeholders. Here's a look at where our revenue projections top out. Again, you see pretty significant growth as reflected by the partnership opportunities. In terms of competition, I would say the queue management companies are closest to what we do because they do manage queues and predict wait times. However, these companies lack EMR integration and they do not apply to any doctor's workflow. They work in urgent care where the flow is linear and where patients are agnostic to which doctor they see, which location they're at, as long as they get seen. This is very different from the vast majority of doctor's appointments where you schedule with your cardiologist, specific office, specific day, specific time. That's where we come in and differentiate. Now, your mobile registration companies and scheduling companies have the EMR integration and can be applied to these different doctors' workflows, but they don't manage queues and they don't predict wait times. And so we do all of this, and that's where we differentiate. In terms of our roadmap, again, working now, looking ahead to 2022 to add EMR integrations, build out our dashboard and intelligent scheduling, which we've already started on, and then looking ahead towards building out the intelligent scheduling platform that I mentioned, with a goal of ultimately being able to help health systems allocate resources based on these different appointment lengths and different patient profiles.
Dr. Miller, I'm so sorry, your time is up. That's a great
Which is
pitch.
perfect, because this is the investment opportunity and the rest I can answer in Q&A.
Excellent. Great job, judges. Let's bring you up for your questions. And we can start first with Karen Miller, and we have 8 minutes of Q&A, which begins now. Karen, looks like Karen didn't have a question. How about Richard Fu? Richard, you go ahead first with your question.
Hi, sure, Jennifer. Thanks for the presentation. Great job. I have a couple of questions. It's more about competition. And so the chart that you presented about ZocDoc and some of the other players, I'm curious about your perspective on how differentiated or how challenging your technology is to actually be developed or mimicked by the likes of a ZocDoc, because I feel that ZocDoc already has a strong position with the many physician practices. How easy might it be for them to actually start to create a similar offering and kind of wipe you out?
Yeah, we get to ask that question a lot. I mean, the beauty of what we've built is that it appears very simple on the outside, and the way we've built the platform and the way we built the interface is that it's very easy for practices to engage with it and use it. But on the back end, it's actually quite complicated. So figuring out what the workflows are in every office and how to manage them and how to make sense out of them. And every doctor's office functions differently. If you've seen one office and the way the workflow occurs, you've seen one office. So understanding what the elements are that need to go in to drive our algorithms and really be able to accurately predict delays is actually quite complex. And you really have to have a deep understanding of how an office works. It's not something that you can build from sitting, an engineer in a room. You have to understand healthcare. You have to understand the differences between different specialties. You have to understand how different patients are. You have to understand the workflow, and then be able to quantify some of those measures and bump those into your algorithms. And so what we've built is actually quite complex.
Next question from Tyler, then Dan, then Josh. Tyler, go ahead.
Yeah, thank you. So I'm curious about when you go into a sales process, how you think about demonstrating ROI here and kind of the value prop that you've shown to a provider system, just to be able to kind of move from taking the call to an actual yes.
Yeah, it's a great question. So we actually have solid data on that. So we have data that shows that we reduce no-shows. So that's money in your pocket right there. We have data that shows that we increase reschedules after cancellations. So there's a whole body of patients who cancel or walk out if you're running too far behind, and then they never come back. So we have data that clearly shows that we increase reschedules after patients cancel. And we also pair our wait time. So we'll let you know if the doctor's running behind. You come in, you have a great experience because you're not waiting in the waiting room. The whole visit goes smoother. We pair that with Google reviews. So we hit the patients up for Google reviews within 5 minutes of leaving. And again, we have solid data that shows that we increase star ratings by 1.5 to 2 stars consistently within 2 months of implementing that. And then we can actually trace back with our practices a volume of new patient referrals into the practice. So between reducing no-shows, increasing reschedules after cancellations, improving online reviews, and new patient referrals, we have really solid data on ROI to the practice.
Got it. Thank you.
Dr. Miller, how many practices did you say you have closed as customers so far? And could you describe what the early adopters look like, sort of typical and sort of size, geography, any characteristics around those that you can share with us?
Yeah, sure. So we have about 50 providers using our platform. That's across 10 practices. So the early customers we had were intentionally, 1, 2 doctor practices. And then we started growing to the larger groups, 10, 15 plus practices. Through our partnership with Epion, the goal is to bring on an additional 4 practices by the end of the year as part of our phase 1 launch, and that should double the number of providers on our practice. We also have the health system contract, which we anticipate the integration being done by the end of the year and beginning the pilot in January. So that will bring another about 30 physicians onto the platform early on. And then as the Epion soft launch progresses and all goes well, that will be scaled across their 500 plus, provider practices.
Okay. Thank you.
Sure.
So I think Josh was actually ahead of me. Do you want to go first, Josh?
Sure. Yeah. Thank you. So this is a pretty interesting application. I appreciate it. I work for Houston Methodist. We're always looking at ways to optimize kind of our patient experience. What does the implementation timeframe look like? And you mentioned some of the algorithms behind the scenes. How intensive is it for practices to implement kind of that if the physician is doing this, it means it's going to be this behind kind of thing?
Yeah. So again, the piece that the practices see, and this is again why this took a long time to build right, because what's going on in the background is very complicated, but what's funneled to the practice is very straightforward. So we gather specific data points at the time of onboarding about the practice. We get an understanding of today's workflow. We get an understanding of physician preferences, staff preferences, everything about the way the office runs. We do that in about a 1 hour initial screening meeting. We also get an understanding of what kind of messaging they want to push out, because we have a ton of optionality built in based on appointment type, event triggers, timing triggers, in addition to the wait time information. The messaging is customizable, so you can kind of push out any messaging you want. So we get a sense of what are their top priorities, what's the messaging they want to push out, and then we put that together again on the back end, set everything up for them. About a week later, meet with them again, review everything, and then turn the system on. And then what we do is we turn the system on in what we call a silent mode, where we run it in the background for a week. We gather metrics and data, meet with the practice again, show them the data, show them how accurately Navimize performed in terms of the wait time predictions, make sure everything's running smoothly. And at that point, we'll turn on. So the implementation, I would say for a group of anywhere up to 30 physicians, is about that cadence that I said. So it'll take about 3 weeks to get it up and running, with about 2 hours of meetings scattered in between.
Thank you.
Hi, Dr. Miller. I had a related question, but it does, on the implementation side, but I'll ask the second part, which is, have you thought about making this more of an API product that works with other sort of software front ends that might be like the ZocDoc or Simply Practice or something like that?
Yeah, 100%. I mean, that's part of our strategy with, we brought on Megan, who's our sales lead now, our biz dev and sales lead person. And one of the things we're looking at are what kind of channel partnerships can we form? So we're looking at companies with synergistic technologies that are already embedded in the market, and where can we add value to what they have just through an API integration. And that's part of the Epyon deal, where they provide mobile registration and they don't have the messaging piece. So we're coming in with the messaging piece, and it'll be an API integration to bring forward. But there's lots of opportunities for us to white label or to add to an existing platform through an API integration. There are some customers we've spoken to who are thinking about using our wait time predictions and displaying it in their in-house app. So we're open to all those kinds of interesting deals.
And I apologize, but our question time is up. Dr. Miller, a great job. And we're now going to take a minute break to give the judges time to enter their scores. And on deck will be next, Jessica Walsh with RX Bands. Great. Please welcome to the stage, Jessica Walsh with RX Bands. Jessica, your time begins now. You have 7 minutes.
There we go. Can you see my screen now?
Yes.
Okay, perfect. So hi, I'm Jessica Walsh. I'm the founder of RX Bands. So first, before I even get started here, I want to thank you for this opportunity to tell you about our very innovative auto-injector. Miniject will provide a game-changing solution for people around the world who need to carry emergency injectable medication. So first, let me tell you how RX Bands came about. I was stung by a bee, had a massive anaphylactic reaction. So off to the ER I go. I'm prescribed to carry an EpiPen with me at all times. I find that they're really big, bulky, temperature sensitive, and there's no great way to carry them. So when I go running, I ended up duct taping it to my arm. I looked ridiculous. They're so embarrassing. I knew there had to be a better way to solve these problems, so I created RX Bands. You see, for me and millions of other people, having your auto-injector or not can often mean the difference between life or death. They have conditions such as anaphylaxis, like I do, diabetes, at risk for overdose, or need biologics or vaccines. The military has also told us that they need our auto-injector to stop pain, deliver anti-chemical warfare agents, and stop non-compressible hemorrhages, which is number one preventable death in the military. But the problem is that current auto-injectors don't meet the needs for patients, first responders, or even the military. In fact, 2/3 of people who are prescribed to carry an EpiPen don't, and then they risk their life. Another 70% don't even remember how to use them a year later. They're also very intimidating to use, which further leads to a delay in administration. And as you might have heard, auto-injectors like EpiPen are very expensive and often left behind in the home car backpack. So it's this huge gap in patient compliance is the problem we set out to solve. So we got to work and we created MiniJect. It's the world's smallest, wearable, durable, thermal-resistant, and cost-effective auto-injector. So MiniJect uses a hydraulic delivery system, which makes it very reliable, and it also can be easily adapted to deliver high viscosity biologics and therapeutics. They're less than 1 ml all the way up to 5 mLs via IM sub-Q. So MiniJect's really easy to use. You just pull off the cap and press this activation button to the person, and it injects in under 1/4 of a second. So that is super fast. So let me show a video, let's see, in slow motion of MiniJect in action here. So you pull off the cap, press it against your leg, activation fires, needle injects and retracts under 1/4 of a second. That's slow motion, by the way. So our internal glass cartridge protection system makes MiniJect very rugged, and it really has to be since it's designed to not only keep up with our military, special forces, and also your average rambunctious child. So the market for the glass cartridge alone is huge, and this technology can be licensed for use in other auto-injectors. MiniJect can also attach to items people carry most. Some of these attachments will be available with data sensors that will provide critical information. So we've partnered with Allergy Force, and they'll support the back-end operation of our accessory attachments. We've also worked very closely with patient sensor inception to be sure MiniJect meets their needs. And MiniJect's a drug delivery platform. So as you can see, there's a number of profitable markets for the many drugs MiniJect can deliver, giving us several shots on goal. So how do we stack up to the competition? MiniJect is less than 2.5 inches long, and we like to think of it as the modern iPhone to EpiPen's old-fashioned phone booth. As you can see, there's been a real lack of innovation. We have a great competitive advantage over other auto-injectors in the market. And we've also taken significant steps to de-risk this company and also the technology. So first, we have a solid design with proven performance. We're also approved for an expedited regulatory pathway, so no clinicals. We have received patents both nationally and internationally, with more to come. And we've been awarded 6 military contracts and have more applications pending. So we've received a little over 1 million in DoD contracts in the last 12 months and tracking to do more than 5 million next year. So our team has made great progress towards FDA approval, and we have about 2 more years to go. And to do this, we were fundraising through a convertible note round, which is currently oversubscribed. The funds are being used to start manufacturing the devices for testing, after which our plan is either to license the device and raise the next 8 to 10 million round at a higher valuation. And this will get us through FDA and commercialize MiniJect. So we're looking at 3 different possible revenue streams. 1, license the device to pharma. And this is a repeatable model for each therapeutic in different markets. Sell the device directly to the military, first responders, and patients, and then sell or out-license accessory attachments. So in terms of licensing, a really good comp is that Sanofi licensed the Square auto-injector you saw before on the other side for $230 million, just to give you an idea of a great comp for licensing. In terms of sales, we've conservatively forecast to hit 5% of the patient population in the first 3 years. That would give us a profit about $45 million. So keep in mind, this projection here is just for only one of our verticals. It's the patient population for the epinephrine market. Our team has decades of experience, and we've brought other auto injectors to market. Just would not have gotten this far without such an amazing team. We've also won many awards along the way. A few highlights: we won RSI International Innovation Award in Vienna, Austria during BioWeek. We were also awarded 2 grants from the very prestigious New England Pediatric Device Consortium. So why have so many other companies invested? We have a breakthrough technology that meets patients' needs in a global market with high revenue potential for multiple therapeutic indications, all run by an experienced team at a de-risked enterprise. We like to say MiniJect is built for health, but styled for life. So thank you for listening. I would love to answer your questions.
Great job, Jessica. Let's open the floor to Q&A and begin with the first judge who has a question, which is Eddie Patton. Eddie, go ahead, and this begins our 8 minutes of Q&A now.
Thank you, Jessica, for the presentation. But going back to your financial slide, tell me a little bit more about how much does it cost to make this? What's your cost of goods sold, and what type of margin are you looking at on this?
Right. So right now, our COGS on this are about $25 before we hit economy of scale. We expect to sell it for around $199. The reason being, we worked closely with patients. We did a patient survey, quantifiable data to represent the entire market. They could have, I'm going to switch to another slide here real quick. They could have picked something as low as $0 all the way up to what some of the other auto injectors are selling for. They picked $199. So we got a really nice data cluster there for $199. I hope that helps to answer your question.
Richard, go ahead with your next question.
Also, similar question tied to your revenue, your pricing model. What's your plan for engaging with health insurance and the payer community?
Right. So auto injectors have J codes. So there's nothing new there for epinephrine auto injector. So we'll follow a similar pathway for other epinephrine auto injectors. Working with the military, we're creating a ketamine auto injector. So let me see. So epinephrine auto injector already set in place, already a J code. So working with the military, we have contracts for epinephrine, so that would fall into J code. Hydromorphone, that's traditionally delivered through needle and syringe. So that would be first military use. That will give us a nice bit of time to have revenue coming in and then get the approvals in place for that. A TXA, we're moving from IV. So we're creating a formulation that will take it from IV to auto injector. So that's a much longer pathway. And then for ketamine, again, traditionally delivered by needle and syringe. So that would require a new J code as well. So our first indication already is something that's there's a code for.
Sarper, your question next.
Yeah, thank you, Jennifer. Thank you so much. So the go-to-market, you have two options: or licensing or individually to sell people, I guess. Of course, the second one will come after all the approvals come in. But my question is, if you license to a company, and that how many companies you can license? Is each on the area, like epinephrine, pain, all others? And if you do so, then when do you decide not to go to the B2C? Because maybe that it's kind of cannibalize each other. So what is the decision-making point on this?
Right. So we've, in terms of the three different possible revenue streams on licensing, we've spoke with a company who's looking to deliver their therapeutic indication for irritable bowel syndrome. That wasn't something that was on a radar. We could license that for worldwide rights, or we could license that for just in their European market. We've also speaking with another organization that has a liquid stable formulation for glucagon, also very interested in using our device to deliver their therapeutic. And that's what we're working on right now, is providing them the data they need to see to be able to continue those conversations. So that's why we're We're in commercial manufacturing molds. We're making the devices to provide them that data. But we have many different options. We can deliver anything short of peanut butter in terms of viscosity. So there's a lot of biologics coming out that we can deliver. Military also loves it because we can fire through a credit card. That's something that a lot of the jet injectors can't do. They can't fire through clothing and whatnot. So we have a lot of opportunities as a drug delivery platform. I hope that helps.
Great. Any other questions for Jessica? We have 3 more minutes left in Q&A. Go ahead, Sarper, you have another one?
Yeah, so you're raising, I kind of missed that slide at 24 million, and then maybe I didn't hear about your exit strategy. Yeah.
Right. So we just closed our closing our convertible note. It's oversubscribed, and so in terms of our exit strategy, we're looking to we can sell off one indication. We can be licensed, so that provides a great payout and huge return for investors. Or we're also being courted right now by a large military contractor that has that sells medical devices around the world. They're very interested in our device, so they may focus on the hydromorphone auto-injector or potentially the whole company. We've had a couple of meetings, so nothing in stone yet.
Ethan?
Hi, Jessica. I'm curious about the IP that you have and kind of the moat that you guys have. I know you have a head start and it seems fantastic, but your timeline slide says like, I can't remember the wording, but additional IP. So I'm curious, like which parts do you have like clear patents on and which ones are you adding on to?
Right. So we have been, our law firms love us because we've been filing so many. So we have IP for the auto injector. We have IP for the the way that we're using the hydraulics for the drug delivery system. We have IP for the internal glass cartridge system in here. So that can be out licensed for use in other auto injectors. So we have also filed IP for that. We're also filing IP. So I can only talk a little bit about it for a rate limiter. That can that's great for the highly viscous biologics, and that can be used inside of our auto injector or also even a pre-filled syringe that provides a significant advantage for many of these very viscous therapeutics that are coming out. So we continue to file. It's not sort of like a one and done thing. We've been on quite a roll.
Great. And that's all our time. We're at 8 minutes for our questions. Jessica, great job. Thank you very much. Judges, we are going to now take a 3-minute break. So go ahead and score your scorecards. And then I believe we'll have a word from Aisha.
Hi there. I wanted to take this opportunity to recognize the Texas Medical Center's innovation group. We could not bring you these great entrepreneurs. Haven't they done a fabulous job this morning? Such interesting innovations and great presentations from the first 3 companies you've heard. We owe quite a bit to the Texas Medical Center's Innovation Group for all their support over the last 5 years. And we are honoring them starting with the semifinals, but you'll see more of our discussions and learnings that we've had side by side with the TMC. When we started 5 years ago, we had 18 or 19 applicants. And we didn't have the processes and the ability to really discover at the level that we have been discovering and learning through the partnership with the TMC. As you notice, we have Megan Howard, who is supporting our efforts. Emily Reiser will be a moderator this afternoon. Emily has been with us for the last several months as we've planned these events. You all know Tom Luby, those of you who are Houstonians and know the TMC well. Tom will be one of our judges in the final event. And we've had years of incredible support from the TMC that has really been, they have been the wind beneath our wings to bring you the quality and caliber of entrepreneurs that you're hearing from this morning. So for those of you who don't know the TMC, we hope that you will come and join us in January so that you can get a firsthand experience, the great work that's being done there. But also we'll share with you just this brief video of the extent of resources and capabilities and what is happening at the Texas Medical Center. We have a brief video to give you a feel.
Largest or the third largest, combine them, they still don't touch the Texas Medical Center. It's staggering. There are 110,000 employees, 170,000 operations a year. It's the largest collection of doctors on the planet. The scale here and the quality of excellence here is staggering. More patients come here, more clinical research happens on this campus. It's the highest concentration of awarded scientists in the world, where you can drive from research to clinical care faster than any other place on earth. What we're trying to do here is take healthcare innovations and research and turn them into products that can help patients. This is a partnership between the Texas Medical Center, the member institutions, and industry. We want the best of the best here, and they are coming, and they're coming in droves. J&J, the largest life science company in the world, here. Next was AT&T. Now we're working with Apple. We are creating this machinery of innovation that is unstoppable. The momentum is real. It's a place that will change the way in which discovery is done. The innovation that is occurring here is tremendous. That you cannot replicate. We have an unfair advantage. We're already together on one campus. This is the beginning of building a life sciences industry in Texas.
And thanks to the TMC, that's how we do the work we do. And with that, we hope you'll join us January 20th to see a more detailed expression of our gratitude. And with that, I'll turn it over back to Sarah to complete the moderation for this session.
Great, thanks, Aisha. Let's bring next to the stage Gail Port. She is with eHealth Analytics. Gail, good luck, and your 7 minutes begins now.
Thank you. This is my widowed Aunt Pauline, who lived to almost 99 years of age on her own until the last few months of her life on a fixed income, enjoying everything Manhattan had to offer, including this meal of Chinese food, which I had the privilege to share with her. She was able to do so because of a combination of good genes, good luck, and the ability to have her healthcare coordinated by a world-class geriatrician. We obviously can't do anything about good genes or good luck, but we are addressing the most important factor, making the skills and services that will be found in a world-class geriatrician available to all patients. Unfortunately, the number of geriatric specialists and care facilities in short supply already is continuing to dramatically decrease each year as the number of seniors on Medicare increases from 55 million today to an estimated 81 million by 2030. 10,000 new beneficiaries are being added to Medicare each day. As you know, seniors typically afflicted with multimorbidities and polypharmacy are the most difficult to treat. exacerbated by the negative impact that loneliness and depression have on their physical condition, which many are reluctant to share with their physicians. A startling fact is that the initial Welcome to Medicare visit, to which everyone is entitled and is the baseline for coordinated care, is only administered to 19% of new beneficiaries. Our solution is based on the comprehensive geriatric assessment, a multidimensional, multidisciplinary process developed in 1963 by Dr. Marjorie Warren in England, the only woman in her medical school class. She was assigned to geriatrics as a specialty because no man in her class would accept it. CGA has been researched, is evidence-based, and proven to extend the quality of life, functionality, and independence of seniors, mostly in the EU and many VA hospitals in the US. Most recently, an algorithm-based controlled study was completed in Linköping, Sweden, a country with excellent healthcare and access to data. This study proved reduced risk of hospitalization, reduced length of stay if admission was required, and a reduction in cost of over $5,000 per patient over 2 years when a CGA was administered. A recent study in the US showed a 5.7% reduction in healthcare costs when the annual wellness visit is administered to even the highest risk group of patients. CGA is a process of which many non-geriatricians have never heard. It's mostly manual and provides no easy way to coordinate care or incentivize its use by primary care physicians. Fortunately, the latter does exist. There are scores of assessments related to this process of which providers and patients are unaware, especially the Welcome to Medicare visit, the annual wellness visit that are reimbursable by CMS. This is just a sample of the different American Geriatric Society patient assessments that are available for care and billing purposes. Our comprehensive senior advisor is an ecosystem that enables easy to use coordination of whole patient care by all members of a senior's care team, caregivers, and patients by developing an integrated care plan based on medical factors and the social determinants of health. Our integrated data and EMR agnostic platform deliver easy to use voice-enabled connectivity between a wide range of physicians, associated medical professionals, RPM telehealth companies, provide services such as the delivery of meals, medications, durables and disposables, and transportation assistance, most of which are Medicare billable activities for which we will automatically send a code to the client's EMR. We've made our voice-enabled platform as easy to use as possible. For our friends in IT, there is no hardware or software to install or configure. Patients can use smartphones, tablets, or computers to interact with the system. And it is a myth that seniors do not use technology. Our platform will be multilingual, integrated with 70+ EMRs, and deliver completed, actionable health risk assessments and billing codes automatically for use by those EMRs. Our multi-factor analysis for targeted alerts will help minimize alert fatigue in physicians. Our goal is, of course, to improve senior care, but there will be no charge to use our platform. But we are in business to make money. Our fee will be a small percentage of the revenue that we will be enabling. We will also charge a subscription fee for access to the large data lake of anonymized machine learning engineered patient information that we will be collecting for independent analysis. These are our target markets. We will not be going door to door asking physicians to sign up for our service. We have identified several potential competitors who offer a subset of our functionality, but certainly not the full range of capabilities. Based on our ability to acquire access to 5% of the initial market of 55 million Medicare beneficiaries, receiving a 10% share of the reimbursements we have enabled based on the number and duration of assessments related to the administration of the IPPE and annual wellness visits, we estimate revenue of over $250 million in our first full year. That number increases as the number of Medicare patients increase to 82 million by 2030, and as we add revenue from our data subscription service and add revenue from ancillary goods and service providers. We currently have a working clickable prototype. We're fairly early. Our plans call for a first pilot based on the annual wellness visit and Welcome to Medicare visits at Weill Cornell Medicine in the first quarter of 2022, with functionality and clients being added through the year, including expanded voice capability, virtual human assistance, analytics for targeted warnings, and additional surveys. Beyond 2022, we will continue to add functionality and expand our geographic scope. This is just our core team. Jackie, Ken, and I have worked together in pioneering technologies in more than 30 years, building large, complex systems at global organizations, and together built a risk management startup that we successfully sold. Dr. Edelman is a longtime associate and advisor of ours. He is the co-head of geriatrics and palliative care at Weill Cornell Medicine, New York Presbyterian Hospital. He is our inspiration for this effort. These are some of the organizations of which we're members, where we have met a number of exciting healthcare startups with whom we will be working as integration partners into our ecosystem. We're not planning to build everything ourselves. We're looking for client partners to help us validate our assumptions, processes, and revenue model, and acquire ample data points for accurate predictive analytics, and to raise $1.5 million for software licenses, additional software engineers, and sales personnel, and 5 months of runway. Thank you, and this is where we can be reached, and we're eager to answer any questions you have. I have my co-founder, Jackie Laver, sitting here next to me.
Gail, thank you so much. Let's open up the floor for questions from our judges. Who wants to go first with a question for Gail from eHealth Analytics? Don't be shy. Go ahead and raise your hand. Josh, thanks so much. Go ahead with your question.
Yeah, what's your vision for integrating into kind of the technologies that hospital systems, possibly LTACs, are using? What's that vision look like? And as you're prototyping out the platform itself, how do you envision that?
We plan to integrate through APIs, through FHIR APIs, and through the EMRs.
We're really tightly integrated with Amazon's health initiatives, if you're familiar with them.
I am.
And one of the partners that we're working with is a company called Redox. Redox will enable us to reach over 70 plus EMRs, as well as integrate very seamlessly with anyone continuing to use just basic FHIR or HL7 as a means of interchanging data.
Okay, thank you very much.
Thanks, Josh. Next question. Who else has a question for Gail? Go ahead, Richard.
Gail, thanks for the presentation. Question about your business model. Could you elaborate a little bit more about how you intend to actually sell and kind of the pricing model that you're envisioning?
Would you like to take that, Jackie? Because Jackie poured through a 7-inch book of CPT codes that are applicable to the surveys and assessments.
Yes, as Gail stated in the presentation, we are not asking for any capital upfront. We're not charging for the use of the system by either providers or tertiary services or the patients themselves. We are hoping to take a 10% gratuity, so to speak, for providing the use of the platform. And that 10% will come from all of the fees that are generated through the use of our platform related to all of these various assessment and evaluation services. We're not going to be charging for treatment services, just evaluation and assessment. Also, our tertiary partners, such as transportation providers and meal providers, will also be charged a 10% gratuity for using the platform and being included in it.
That percentage of the CPT billing is currently money that's being left on the table by physicians right now and healthcare systems, because they don't know that these codes exist and are not using them. And we're enabling their use automatically.
And then quick follow-up to that. Have you all thought about your relationships with the health insurers and the payers as being a key sort of channel to that?
Yes, we have. We've considered that very carefully. And we actually see Medicare Advantage plans as being our #1 target. And in fact, at Weill Cornell, where we're going to be working with Dr. Edelman's department, they also have their own Medicare Advantage plan. And that is the first plan that we're hoping to add as a result of working through the first pilot with Dr. Edelman and his group.
Many of the large hospital systems have their own Medicare Advantage plans, we've found.
Okay, Richard. Wendy, your question is next.
Great, thank you. I was interested in how you're gathering the data, and are you using or incorporating any sensors in the platform?
The data is actually being gathered in a couple of different ways. The primary way is through the EMRs, but we also have some partnerships with remote patient monitoring and telehealth companies. So any place that there are devices used in the home or in a hospital setting, we will be collecting data through those partnerships to add to our data lake, as well as, and also to help inform our predictive analytics for intelligent alerting.
Okay, thank you.
You're welcome.
Other questions for Gail with eHealth Analytics? Going once, going twice. You're getting off easy, I tell you what.
Well, either we explained it very well, or people aren't interested. I'm not sure.
You explained it excellently. So if there are no other questions from the judges, we'll go ahead and move forward. Going once, going twice. Gail, thank you so very much.
You're welcome. Thank you for the opportunity.
Yeah, great presentation. That's a great story about your mom as well. So next up to the stage for our next presenter is going to be Courtney Williams, our last presenter. And so while we do that, we're going to take a minute break. So judges, you go ahead and score your cards, and we'll come back in a minute in order to see our next presentation. Okay, now we are ready for our final presenter. So let's welcome to the stage Courtney Williams. Courtney, how you doing? And she is with adorable picture there with Imagine Solutions, and your time of 7 minutes begins now. Good luck.
Wonderful. Thank you so much. I gave birth at the height of the pandemic. A few days after coming home, I got a headache that wouldn't go away. I was getting alarming chest pain, and I was having trouble breathing. I'd been studying women's health for years, and I knew what was happening. I went to the hospital and demanded to be treated for a condition called preeclampsia. And good thing I did, because had I waited just a few more hours, it could have cost me my life. Preeclampsia is a condition that affects 1 in 20 pregnancies in our country. And it is the cause of 60% of maternal deaths. As you all know, we are in a maternal health crisis in this country, where our maternal death rate is actually the highest in the developed world. Not only is this costly in terms of lives, but this one condition of preeclampsia costs the system over $2 billion each year. Having gone through this and experienced the patient perspective, I wanted to do something to help. So my team and I created the first platform of its kind for remote patient monitoring for pregnancy care. My name is Courtney Williams, co-founder and CEO of Imagine Solutions Technology. Thanks so much for having me here. I'm excited to tell you about what we're working on. Our solution starts with the patient. The Journey Patient app is a tool for patients to track their own health and advocate for themselves. This is where patients can log and track their symptoms and their vitals from positive pregnancy tests all the way through postpartum recovery. The information that they track is important health information that could be used to diagnose conditions such as preeclampsia and other conditions in pregnancy. So we're talking about health data such as your blood pressure, weight, symptoms, and more. This information flows directly to our provider platform, the Journey Clinic, and providers can access their patients' trends in real time, boosting efficiency and their ability to have more personalized and focused patient encounters. If the provider needs more information from a diagnostic perspective, they can use our FDA-cleared handheld ultrasound VistaScan in prenatal care appointments. This is a technology that is handheld, it's patented, FDA cleared, and it's a 10th the cost of a regular cart ultrasound system. This is a technology to be used outside of the typical 2 ultrasound scans that patients get during the course of a regular pregnancy, a normal pregnancy in the US. All of these together make a powerfully, fully remote pregnancy monitoring platform designed to catch issues early so doctors have enough time to treat them. This is a technology that works as decision support for providers to specifically address the expensive and also dangerous condition of preeclampsia. However, our platform helps address the plethora of other conditions that actually can occur in pregnancy and cause anxiety for patients and their providers, such as gestational diabetes, among other conditions. Remote patient monitoring, which is where this technology sits, is a really hot area right now, helped along by COVID, actually. It's currently experiencing 40% market growth, projected to be a $100 billion market by 2025. Women's health tech, or femtech, is a $50 billion market, of which pregnancy care actually just makes up about $500 million to date. Handheld ultrasound is a $1 billion market, and we believe that these factors combine to make a very attractive market opportunity. Pregnancy care has been historically underserved, but we are definitely determined to change that in a major way. Further, when it comes to women's health, the market has been really focused on educational tools and fetal growth. And what makes us unique is the fact that we are a diagnostic technology to improve safety for maternal health from the mother or the birthing person's perspective. Our technology is specifically designed to make providers' lives easier, while also giving them the data to be able to help them reduce risk and manage their patient load more efficiently. Benefits of our solution are not just life-saving, they're also monetary. This platform starts paying for itself from day one, with an ROI in less than 4 months. It also increases patient satisfaction by an estimated 10% and enables providers to shave 1 to 3 minutes per patient visit, enabling them to see potentially an additional patient per day, which obviously has really significant revenue implications for a health system. And plus, the unspoken benefit here is the fact that this platform really does have the power to reduce maternal health disparities that are so prevalent in our country. In terms of milestones, we are FDA 510(k) cleared with a granted utility patent, early revenue, and an SBIR Phase 1 grant from National Science Foundation. This year, as we are poised to launch our patient app, we're projecting 1,000 app downloads, 500 patients on our platform, and 5 clinic customers by the end of this year. Right now, we are fundraising for our seed round, and we're already getting actually inquiries about potential acquisition. But aside from the fundraise component here, our biggest ask today is for pilot partners who can implement our solution and our platform and give us feedback. Our team has deep experience with the issue of women's healthcare. From my perspective, I share my patient perspective. I also have an MBA and a background in customer analytics. And my co-founder, Jose, is a software engineering expert and former Google engineer. We have a strong advisory team of clinicians and healthcare business experts who not only share our vision for improving maternal healthcare, but also see this as a major business opportunity and are helping guide us on our path to growth. We are Imagine Solutions Technology, remote patient monitoring for maternal healthcare. Join us on our mission to empower patients and ensure providers have better quality diagnostic information. So together we can improve women's healthcare and outcomes. Thank you.
Great. Courtney, nice job. And you've got a minute to spare. So let's go ahead and start with Q&A with the judges. Who would like to ask the first question? Thank you, Ben Johnson. Go ahead with your question for Courtney from Imagine.
Yeah, thank you once again, Courtney, for the presentation. Just a couple quick clarification questions. One of them is related to IP. So I'm looking at, looks like you have IP in the device and you have IP in the software. Just want to clarify that. It's all that is under your IP domain, or is any of this somebody else's IP that you're bringing in?
We are a hardware agnostic handheld ultrasound. So the IP is not on the hardware piece. There are 3 ultrasound probes that work with our solution. And we like white label them for our, we work with an OEM manufacturer that's based in the US. Our IP is all around the software. So on one hand, we have a granted utility patent on our precise point measuring system on our handheld ultrasound. Enables clinicians to be able to do diagnosis a lot quicker and better on the ultrasound image that they generate. And we're also in the early stages of a filing for the AI that we're developing for preeclampsia.
Okay, thanks. And I'll hold off on my other question until later.
Okay.
Josh, go ahead with your question, followed by Richard.
Yeah, thank you. Great presentation. How do you envision getting these devices to the patient? Do they need to pick them up from the office? Are they mailed? Are they purchased? Like how does the patient get the information, tie the app to the physician so that they can start to exchange and work with each other?
Okay, yes. So to be clear, so with our solution, this is the patient side today. They are using the patient app that we've developed. They download that patient app. It's a free download from the Google Play or iOS store. And this is a clinical pregnancy tracker is how we're classifying this. And so they're able to input their information that they would have normally kept a paper log for. That's how the state of things is today. And so the FDA is not on board yet with patients doing their own ultrasounds at home. And our long-term view and vision is to be able to connect the handheld ultrasound, obviously, to the patient app. We've built our app in order to be able to do that and kind of flip a switch when, from a regulatory perspective, that is acceptable. As it is today, the handheld ultrasound is being used during the course of regular prenatal appointments. This is being used by the provider. And instead of using the fetal Doppler, which is a really old and outdated tool just to hear fetal heart tones, they're able to do 3 basic ultrasound exams for prenatal care instead on this handheld ultrasound and get more diagnostic information, put the patient and the provider at ease, as well as be able to bill for those exams.
Great. Next question, I believe, from Richard.
I actually had a very similar question to Josh, but you answered it. But I'll use this time to ask a different question, more about your market expansion ambitions. A few fold. One is I think this handheld ultrasound sort of component could be extremely valuable, especially for emerging markets, as well as perhaps even for our markets and here in the US, where there's a big disparity in care, especially maternal health. How are you thinking about kind of further growth beyond kind of what you've currently planned right now?
Yeah, our early beta revenue is actually indicating kind of where the potential opportunities are for that. So when we, as we've been developing our solution, we want to make sure that this is a solution that while we're going to start in the US, because we have such a great and diverse market and we have such great need here, and that's where our market, our go-to-market strategy begins. Our handheld ultrasound is already the main ultrasound in 4 hospitals in Haiti. And we're already working with a partner for that. We're also working with the Indian Health Service to help close the gap in terms of rural health. Here in the Southwest. I'm based in Arizona. And so we see already a lot of opportunities to be able to build on those experiences and be able to scale in emerging markets. Our go-to-market path in emerging markets starts with the US, as I mentioned, and then we already have expansion plans for other areas in the Americas, which is really where our main focus is going to be, with half of our team either being from South America or currently being in South America right now. We have a great footprint there and a cultural understanding to be able to expand effectively.
Great, thanks, Richard. Eddie, your question next.
Yeah, expanding on that a little bit, your marketing strategy, are you going to start with just patients with this market strategy, or are you focusing on OBGYN clinics to then take this to their patients?
It's a double-edged strategy. So in our patient app, we've developed a way for patients to share their success and their use of this app with their provider. And so that is going to spur providers to be like, hey, this is really interesting, and to be interested in adopting. On the provider side, obviously, we have a strong marketing strategy that we've developed to be able to attend ACOG, present findings from our 4 clinical studies that are currently in progress, do published publications for our research that is currently in process, among other things. So we have a double-edged strategy at the same time to be able to get this technology to market and to scale as quickly as possible.
Great. Sarper, your question is next, followed by Dr. Hill.
Yeah, thank you. I just a little follow-up question that seems like a go-to-market is a favorite question. As I work in emerging markets only, so then, and I do realize that you're focusing on the US is the right strategy to do it. But so then in case of working with the hospitals and providers, are you thinking to do like white labeling and then for them to brand their own? And it's because you're also going as your own brand to the B2C.
Yes. Long term, when we start working with larger medical systems, absolutely, like white labeling is definitely a possibility. But right now, in terms of our go-to-market, we're really focused on the solo practice OBGYN providers. So there's private practice clinics that are 53% of the US OBGYN provider space. Those providers, we've done extensive customer discovery with them, and they don't need the white labeling as much as a large medical system does. And we are not targeting those large medical systems until year 3 of our product expansion. So that is definitely in the works, but at this point, the customers that we've been speaking with are not as concerned about that as we had initially thought.
Thank you.
Dr. Hill, your question next.
Sure. My question's around the ultrasound piece, and particularly since you're targeting independent or small practices. Does the cost of your software, is it cheaper than, say, a machine, and is your resolution the same? And third prong to that question is, a lot of people are looking at 3D ultrasounds, the pretty pictures for the moms. How does that compare? And fourth part of that is insurance reimbursement. Typically, insurance reimburses only for 2 or 3, particularly in a normal pregnancy ultrasounds. If you add those, your reimbursement, have you looked at whether, they'll be paid for that? Sorry for the 4 parts, but.
And you've got 30 seconds. Sorry, Courtney.
Okay, there are established CPT codes for the insurance reimbursement, especially if the patient has a risk profile. That would fall outside the typical insurance bundling. The second question that you asked was about the resolution. This provides excellent B-mode imaging that's on par with a medium quality cart-based ultrasound machine. I don't know if I can get to the other answers with the amount of time, but I would love to follow up with you afterwards to answer your additional questions.
Thank you, Courtney.
Thank you.
Great, Courtney, thanks so much. And thanks again to all of the companies here today. Phenomenal what you're building. And with that, I would like to conclude this session and also hand the floor to Aisha to give you a little bit more of a send off. But keep going, ladies. What you're building is very important.
Sarah, thank you. Fabulous job moderating. We're delighted to have you back and want to celebrate the continued success you are having with your company, Helium. So if anyone wants to see more about Sarah's real day job, I think the website is Try Helium, and you can get a feel for the work that Sarah does and the advancements of her company. Thank you, Sarah, for doing this today. To the presenters, fabulous job, 5 great presentations today. So thank you for such a great job. To the judges, you all are incredible. Love having this great group, great questions. It's a good exercise for the entrepreneurs to have the expertise that you bring to the table and the questions that you're posing for them. So thank you for that. This has been an outstanding session. I have just 3 things to remind you. For judges, please be sure to complete and press submit. Yesterday, we had someone complete but didn't press submit, so we had to chase after them. So we appreciate you getting your assessments done. For everyone, the People's Choice Award, take a look at the recordings as they get posted. We're excited about this year's startups and looking forward to seeing how many of them can make it to finals. And then thirdly and last, keep an eye out for the announcement for the winners. We're gonna make it really exciting. It'll come out on Monday. We're excited to kind of see where this thing lands. We've got some outstanding companies, great competition. So thank you all for a great morning session today. Appreciate everyone's time and participation.